Hello and welcome to the topic endocarditis in the cardiology module. By the end of this topic, you should be able to define endocarditis, discuss the epidemiology of endocarditis, outline the pathophysiology and causes of endocarditis, outline the classification of endocarditis, describe the clinical manifestations, outline the investigations to diagnose and assess the severity, and finally discuss the principles of management and the complications of endocarditis. Let's get started. The term endocarditis is derived from the ancient Greek term endon, which means inner or internal, and carditis, which refers to the inflammation of the heart muscles. Endocarditis is the infection of the endocardial surface of the heart involving one or more valves. The strongest risk factor for developing infective endocarditis is a previous episode of endocarditis. The following types of patients can be affected: previously normal valves, where the mitral valve is most commonly affected, rheumatic valve disease, prosthetic valves, congenital heart defects, and those intravenous drug users, which typically causes tricuspid lesions. The heart wall consists of 3 layers, with the outermost layer being the epicardium, moving in its myocardium, and lastly the endocardium, the innermost layer of the heart. And this is the layer that gets inflamed in endocarditis. So we will now move on to the pathophysiology. Endocarditis happens when there is endothelial injury, either through inflammatory or direct injury, which can be from infection, which then leads to exposure of the collagen and tissue factors, subsequently adhesion of platelets and fibrin, and lastly thrombotic episodes happen, which is also known as non-bacterial thrombotic endocarditis or NBTE. Infective endocarditis happens when non-bacterial thrombotic endocarditis occurs with the presence of bacteremia. Bacteremia happens when microbes enter the bloodstream, then adhere to the endothelium via surface adhesion molecules and create a biofilm, which the bacteria adheres to lower pressure area and the edge, and this can be explained with the Venturi effect. Subsequently, cytokine is produced, leading to intracardiac structures damaged, then embolization of vegetation fragments, hematogenous infection of sites during bacteremia, and finally tissue injury. As we move on to the causes of endocarditis, they are largely divided into infective and non-infective causes. Infective causes are further divided into culture-positive and culture-negative endocarditis. Among the non-infective causes of endocarditis include systemic lupus erythematosus or Lippmann-Sachs endocarditis and malignancies such as merantic endocarditis. Staphylococcus aureus is now the most common cause of infective endocarditis. It is particularly common in acute presentation and amongst intravenous drug users. Historically, Streptococcus viridans was the most common cause of infective endocarditis. This is no longer the case except in developing countries. Technically, Streptococcus viridans is a pseudotaxonomic term referring to viridans streptococci rather than a particular organism. The two most notable viridan streptococci are Streptococcus mitis and Streptococcus sanguinis. They are both commonly found in the mouth and in particular dental plaques, so endocarditis caused by these organisms are usually linked with poor dental hygiene or following a dental procedure. Next is coagulase-negative staphylococci such as Staphylococcus epidermidis. This bacteria commonly colonizes indwelling lines and are the most common cause of endocarditis in patients following prosthetic valve surgery, usually the result of perioperative contamination. After 2 months, the spectrum of organisms which cause endocarditis can return to normal, which is Staphylococcus aureus being the most common cause. Next, let's take a look at Streptococcus bovis, which is associated with colorectal cancer. The subtype Streptococcus galolyticus is most linked with colorectal cancer. How about culture-negative causes? These are those who received prior antibiotic therapy, infections caused by Coxiella burnetii, Bartonella, Brucella, and the Hay-Sac organisms, which are the Haemophilus, Actinobacillus, Cardiobacterium, Eikenella, and Kingella. Endocarditis can be classified based on clinical presentation and by nidus or location of infection. Based on the clinical classification, endocarditis is classified into acute, which happens from days to weeks, subacute, weeks to months, and chronic, which happens over a duration of more than 3 months. Another common classification used is the nidus or infection location, whether the affected valves are the native valves, prosthetic valves, or right-sided versus left-sided endocarditis. Endocarditis should be considered a differential diagnosis in any unwell patient with relevant risk factors. Fever accounts as the commonest presentation, which is associated with chills, anorexia, and weight loss. Other non-specific features include malaise, arthralgia, myalgia, night sweats, and abdominal pain. In complicated cases, one may present with associated focal weakness, which happens due to systemic emboli, which results in asymmetric weakness consistent with a stroke. The diagnostic and associated signs of endocarditis can be divided into cardiac and extracardiac manifestations. For cardiac manifestations, patients can present with new or changed heart murmur, which mitral valve is most commonly affected, followed by aortic valve and then tricuspid valve. What happens is valve destruction and severe regurgitation or valve obstruction. Besides heart murmur, heart failure can occur as well due to valve insufficiency, where patients present with dyspnea and lower limb edema. Lastly, arrhythmias can occur, hence perivalvular abscess should be suspected. For extracardiac manifestations, patient can present as petechia in the fingers, which is known as splinter hemorrhage. Janeway lesions, which is due to smaller emboli, blocking smaller vessels, and microinfarction are among other cutaneous manifestations seen in endocarditis. Osseous nodes and can also occur as well due to immune complexes deposited subcutaneously. Rod spots happen due to immune complexes causing vasculitis in retinal vessels. The next extracardiac manifestation is acute kidney injury, which happens due to immune complexes deposited in the kidney which damages the glomeruli. Splenomegaly can also happen due to septic abscess resulting from emboli. Patients with endocarditis can present with septic embolic stroke, signs of pulmonary embolism, arthritis, and meningeal signs which result from septic emboli. This is the diagnostic criteria used for infective endocarditis, which is known as the modified Duke criteria. The criteria is made up of major and minor criteria, where to make a definitive diagnosis, you will need 2 major or 1 major and 3 minor or 5 minor criteria. Lab investigations that can be used in diagnosis are full blood count to look for nomocytic nomochromic anemia, leukocytosis with left shift, blood cultures to identify the organisms, as well as inflammatory markers such as C-reactive protein and erythrocyte sedimentation rate, which are usually elevated in the case of endocarditis. For imaging tests, echocardiography can be used to confirm or rule out the diagnosis, as well as to evaluate complications and prognosis. Transthoracic echocardiography can be used to detect native valve infective endocarditis, but it cannot identify vegetations that are less than 2 mm in size. On the other hand, transesophageal echocardiography is useful in infective endocarditis related to prosthetic valve or intracardiac devices. It can detect more than 90% of the vegetations present. For severity tests, it can also be divided into lab and imaging investigations. Lab investigations include serum urea, electrolyte and glucose levels, liver function tests, urinalysis to look for active sediments and microscopic hematuria in the case of septic emboli. Besides that, urine analysis can also look for red blood cells and white blood casts, proteinuria, and pyuria. Imaging tests that can be done include CT scans to look for emboli in the spleen, brain, and etc. ECG is done to detect any heart block, for example, prolonged PR interval, non-specific ST or T-wave abnormalities, and AV blocks can be detected as well. For rheumatic fever, there will be positive anti-streptolysin O antibodies or anti-DNA B antibodies. Echocardiogram can be used to diagnose congestive cardiac failure with globalized carditis, which lacks specific vegetations seen in infective endocarditis. Endomyocardial biopsy can be done to look for Aschoff bodies. In the case of Liebman-Sachs endocarditis, there will be positive autoantibody profile, immunohistochemical staining lacking neutrophil, or characteristic inflammatory response as seen in infective endocarditis. We are now done with the investigations. Let's proceed with the next part, which is the principles of management. The first part of management we'll be talking about is ways to relieve symptoms. Patients commonly complain of having fever and will be exhibiting a febrile state. In complicated situations, they may also have dyspnea due to congestive cardiac failure. Here, oxygen therapy and diuretics are pertinent. Antipyretic drugs can be used, for instance acetaminophen, but most importantly is to treat the infection. As for the second part, we can talk about the measures to treat. Multidisciplinary approach should be initiated with specialty from infectious disease or microbiology, cardiology, and cardiac surgery specialists involved. There are a couple of factors taken into consideration when administering effective antibiotics therapy for patients whom have a strong suspicion of endocarditis, namely the severity of the infection and the classification of the infection, whether it is a native valve infection or a prosthetic valve, mitral or tricuspid valve, or if there are any intracardiac devices or catheter which may have led to the infection. These factors provide physicians a better idea on the causative agent of the infection. Empirical antibiotics are initiated once adequate blood culture samples have been taken. Look for the source of infection and remove it as soon as possible to eradicate the infection. In native valve endocarditis, vancomycin plus beta-lactam, for example, ceftriaxone and cefepime is the antibiotic of choice. For the case of prosthetic valve endocarditis, add gentamicin plus rifampin or vancomycin plus beta-lactam if less than 1 year after placement. Targeted antibiotics should be at least 2 to 6 weeks after the first sterile blood culture. Early valve surgery is indicated in severe valvular incompetency, aortic abscess, which is often indicated by a lengthening PR interval, infections resistant to antibiotics or fungal infections, cardiac failure refractory to standard medical therapy, and recurrent emboli after antibiotic therapy. Delay in diagnosis or treatment can lead to a variety of complications which can be broadly classified into cardiac complications that are associated with metastatic infections. Valvular insufficiency leading to congestive heart failure is the commonest complication of infective endocarditis and is therefore the most common indication for surgical management of endocarditis. Other cardiac complications include pericarditis and perivalvular abscess. Next are complications associated with metastatic infections. These include embolization, which can then lead to distant organ and tissue complications such as pulmonary, neurologic, renal, musculoskeletal, and splenic infarction, as well as infections which can then also lead to abscess formation. Poor prognostic factors include Staphylococcus aureus infection, prosthetic valves, especially early, acquired during surgery, culture negative endocarditis, and having low complement levels. Mortality of the condition depends according to the organisms involved. In summary, endocarditis is the inflammation of the endocardial surface of the heart plus valvular structures, chorda tendineae, sites of septal defects, or the mural endocardium. Endothelial injury allows the formation of non-bacterial thrombosis over the affected site, and when coupled with bacteremia, this results in infective endocarditis. Common bacterial pathogens which cause endocarditis include viridans strep, Staphylococcus aureus, gram-negative HEC groups, fungal infections like Candida, and Aspergillus fumigatus. Endocarditis can be clinically classified based on its onset duration, which are acute, subacute, and chronic. It can also be classified based on the nidus of infection locations such as native valve endocarditis, prosthetic valve endocarditis, device-related, and right heart endocarditis. Symptoms are non-specific constitutional symptoms like fever, malaise, weight loss, and shortness of breath. Always suspect endocarditis in a patient with prolonged fever of unknown origin. Signs to expect include murmurs, arrhythmias, splinter hemorrhages, oscillous nodes, Janeway lesions, and rod spots. Unilateral weakness or focal neurology may indicate complications of endocarditis secondary to septic emboli. Diagnosis is made using the modified Duke criteria together with results acquired from a full blood count, blood cultures, CRP and ESR, and echocardiography. If there is a strong suspicion of infective endocarditis and the patient is acutely unwell, initiating empirical antibiotics is recommended, but only after adequate blood culture samples have been taken. The choice of antibiotic depends on the following factors, which may help predict the different causative organisms, whether it is affecting the native valve, prosthetic valve, or in people who inject drugs, as the location of the infection would likely differ than the typical areas. Early surgical intervention is indicated if there are complications seen such as infective endocarditis-associated valvular regurgitation or dysfunction, heart failure, intracardiac abscess, and persistent infection or difficulty to treat the organism. We have come to the end of this topic. Thank you.